Good afternoon, everybody, and thank you for the kind invitation to this meeting. It's an honor for me to be here. Since the expiry of the Da Vinci patent, several new robotic platforms entered the market, leading to the current scenario, and I would say finally. So among these new robotic platforms, one of the first on the market was the CMR Versius robotics system. It was born in 2014, and the main aim of the company was to product a system to solve some problems still present with robotic surgery. So with the main aim to increase the adoption of robotic surgery. And the system development was performed with the strict collaboration with the surgeons from the very beginning of the first prototype till the final product, with human studies performed in 2019. So looking at how the system looks like today, it is a modular system with an open console that is connected to a bedside visualization unit and up to 3 operating bedside units. As you can see, the bedside units are mounted each one on a separate cart, and thanks to the small size, the system doesn't need a dedicated operating room, so it can be moved from one OR to another. The rationale behind the open console is to facilitate the communication between the operating surgeon and the operating room staff. So what we normally do in laparoscopic surgery and even in the open approach. The joystick light and controller are equipped with all the functionality, so including the camera control with both ends and even the energy control, so without any need for pedal control. The bedside units are made by a cart with an arm mounted on it. And as you can see, the arm mimics the shape of the human arm, so with the base, an elbow, and even a V-wrist and a distal end. So if you have a look at how the system looks like from the outside, it's quite small. You can see that the surgeon is taller than the system itself, and he has an easy access to the patient. And having a look at the handle, you can see that how the movements are smooth and easy to use. I'm using the handle in that video. My hand size is 6, and I don't have any kind of problem using the handle of the CMR, while on the other hand, I have several problems in using standard laparoscopic instruments. Even the removal of the system is easy. You just have to press 2 buttons and then to push away the bedside unit. This is fundamental in case of an emergency, so the system is even safe. The Versius has a monopolar hook, scissors, bipolar grasper, and needle holder as instruments, and all of them has a 5mm shaft, so the system doesn't need dedicated port, but all the laparoscopic port on the market can be used. And the system is working on the energy device that is coming soon. The bedside unit for the visualization is connected to a camera endoscope. The endoscope is from the Wolf technology, allowing a 3D vision in full HD, and a 0-degree and a 30-degree angle are available. They recently came out with the Limelight software, enabling the ICG fluorescence visualization thanks to a dedicated scope and camera. So actually, the rationale of this system is to thinking laparoscopically and operating robotically. Indeed, it has all the advantages of robotic surgery, so the dexterity, the vision, and the precision, but you don't need to modify your laparoscopic technique, and you don't need to modify the port placement of your laparoscopic technique. So this system allows you to do a fully robotical procedure, but even an hybrid procedure, so you can use your standard laparoscopic procedure for one part, for some steps of the surgery, and the robot for another one. This is an example. On the left, you have our standard laparoscopic port placement for a TME, which is the same, identical for the robotic CMR Versius TME on the upper part of your right, while it is really different from the Da Vinci TME. As all the robotic system, even the CMR needs a formal training to be completed before starting the clinical experience. They recently introduced an optional immersive virtual reality headset for the training, allowing the trainer to perform some practice for the setting of the OR. And in this randomized control trial, including 23 students, they compared the effectiveness of the standard training with the virtual reality training, and they concluded that This training is associated with a more ability of the trainee to complete the task without any kind of physical assistance. So looking at surgical data, global data, the system is spread in 20 countries all over the world with more than 18,000 procedures completed. As it is a versatile system, it is used not only in general surgery, but even in thoracic, urology, and gynecology. These are some results of the first 2,000 cases from the multi-center prospective data registry. You can see this one that are the most frequent procedures in this registry. And one of the key points when talking about this new robotic system is the need to convert in another approach. So in laparoscopy, standard laparoscopy, or an open approach. And the needs for general surgical procedure was between 3 and 13 according to the procedure. Obviously, this number regards the very beginning of the learning curve, so they're going to be lower in the future. Regarding our experience in the Polyclinical Hospital of Milan, we introduced the system in 2021. We completed almost 100 procedures, and 85% of them were with an hybrid approach. And we needed to convert to standard laparoscopy in 2 cases, mainly due to the lack of an energy device. So looking at some examples, here you have on your left a right colectomy with a CME, and on the right a TME. You can see that at the very beginning, in both cases, you have to perform the setup of the system, so with the placement of the bedside units, the shape of the arm, and the port training. The port training is a kind of training the system needs to understand where is the fulcrum at the level of the abdominal wall and which is the working area. And it is because the instrument is not locked to the port. So you can see that in the CME, there is the vascular dissection using the monopolar hook and the bipolar energy with the left hand, while the dissection during the TME is performed using the scissors. You can see that there are some colored icons on the monitor, so to help the staff understanding that the surgeon is using the monopolar hook on the left hand and the bipolar on the right. Oh, I'm sorry, on the left and the bipolar on the left. And when he's using the electrocautery. Other examples from upper GI surgery, so a gastric resection on the left and the thoracic part of an esophagectomy on the right. Once again, the setup of the system, and you can see the lymphadenectomy with the vascular dissection using the monopolar hook and the bipolar during the gastric resection. While for the esophagectomy, you can see the dissection of the esophagus and even the use of the needle holders for the fashioning of the purse string for the esophageal anastomosis. You can see that I can always find my place between 2 of the bedside units because the system is small and I have an easy access to the patients, so I can use the accessory port for the suction or the clip applier, whatever is needed. If robotic surgery allows us to do what is undoable with the standard laparoscopy, to see the invisible, we need ICG fluorescence. And now it is possible with with the new software, Limelight. You can see on the left an ICG cholangiography during laparoscopic cholecystectomy with a comparison with the Storz Rubina on the bottom part of the slide in the same patient. You can see that they have a good overlay of the technology. The blue color is for a colorblind colleague. We have one of them in our staff. And on the right part of the slide, you can see an ICG angiography to control the good perfusion of a spleen after a distal pancreatectomy. And you can see the different modes on the right part of the slide, so the overlay and then the grayscale apart from the white light, obviously. You can see that from the cholangiography, the intensity of the image and of the ICG is very good with a perfect signal to background ratio. And it is because the system has a kind of automatized modulation of the ICG fluorescence. So looking at some literature data, this is a systematic review, including 300 patients with 48% of colorectal cases. None of the complications were connected to the system, and the conversion to laparoscopy or open surgery was between 4 and 60% for colorectal cases. And the setup of the system was between 11 and 17 minutes, according to the case series. So the system was concluded to be safe and effective. And this is one of the biggest case series, including 160 procedures with 68 colorectal cases. Once again, the conversion to another approach was 4% for colorectal procedures, and the bedside unit time to set everything was between 11 and 12 minutes in all the specialties. So in conclusion, new robotic platforms are here to stay, obviously, and this is good because competition among companies is always good because it allows us to have greater product on the market. There is need for sustainable robotic system, and as in abdominal surgery, some procedures need the robotic approach only for some steps. The CMR can be appealing because it allows us to perform a fully robotically, but even an hybrid procedure. And I thank you for your attention.